Vanessa Yasmin Udinas from BSN 3D, and today I will be performing a neurological assessment which included the sensory, cerebellar, motor, and the reflexes. Introduce yourself and verify the client's identity. Good morning po, I'm Vanessa Yasmin Udinas. Pwede niyo po ba banggitin ang pangalan? Kailan po birthday niya?
February 22, 1972.
Ilan taon na kayo ngayon? Okay, then after that is to explain what are you going to do, why is it necessary, and how the patient can participate. So, ngayon po, magsasagawa ako ng isang assessment o pagsusuri para malaman kung maayos na po ito function sa mga nerves nyo po, tsaka reflexes, mga kalamnan.
Ayos pa ba ang gamot?
And after that is to perform hand hygiene and wear mask. Then after that is to provide the client's privacy. Then position yourself appropriately in front of the client or the examination table or bed. Then after that is to position the client according to their level of consciousness. Alam niyo po ba kung nasaan kayo ngayon? Anong araw ngayon?
First is to assess the sensory function. For pain, apply the lightest pressure needed for the stimulus to feel and ask the client, is this sharp or dull? For temperature, a tuning fork heated or cooled by water, then touch the skin and ask the patient to identify whether it is hot or cold.
Init. Init. Malamig. Malamig.
For light touch, with the fine whips of cotton, touch the skin lightly, avoiding pressure, then ask the patient to respond whenever the touch is felt and to compare one area with another if the same or not. For vibration, tap a relatively low-pitched tuning fork on the heel of your hand, then place it firmly over a distal interphalangeal joint of the client's finger. Then ask whether it is pressure or vibration. Then ask the client to tell you when the vibration stops. Then touch the fork to stop it. For position, grasp the patient's big toe, holding it by sides between your thumb and index finger, then pull it away from the other toe so as to avoid friction. Then demonstrate up and down as you move the patient's toe clearly upward and then downward. Then with the client's eyes closed, ask for a response of up or down when moving the toe in a small arc. Then repeat several times on each side, avoiding simple alteration of the stimuli. Next is for discriminative sensation. Screen a patient with stereognosis. Place in the client's hand a familiar object such as coin, paper clip or pencil, then ask the client to tell you what it is, one at a time. Normally, a patient will manipulate it skillfully and identify it correctly.
Ano piso, kaya ano na yun? Button? Paper clip, stick, ball pen. Okay, without looking. Ito yung kamay mo. Ano yun
Paper clip. Piso. Stick.
Batsag yung stick mo, batsag mo na stick. Toothpick.
Ballpen. Bote.
Kawiri, ay kapa eh.
Bote. Piso. Paper clip. Stick.
Very good.
The next, number or letter identification. With the blunt end of pen or pencil, draw a large number in the patient's palm. Then a normal person can identify most such numbers.
Six. Five. Seven. Eight.
For two-point discrimination, using two ends of an open paper clip or two sides of two pins, touch a finger pad into two places simultaneously, then alternate the double stimulus irregularly with a one-point touch. Be careful not to cause pain, then find the minimal distance at which the patient can discriminate. Next is to assess the cerebellar function, rapid alternating movements in the arms. Observe the speed, rhythm, and the smoothness of the movement. Repeat with the other hand. And then the non-dominant hand often perform less. Strike one hand on the thigh, raise the hand, turn it over, then strike the back of the hand on the same place. The client had to repeat this alternating movement as rapidly as possible. Now for the point-to-point movements in the arms, ask the patient to touch your index finger and then his nose alternately several times. Move your finger about so the patient has to alter direction and extend the arm fully to reach it. Normally, the patient movements are smooth and accurate. Then after several repeats, ask the client to close both eyes, try several more times, repeat on the other side. Normally, a person can touch the examiner's finger successfully with eyes open or closed. Next is the gait or other related movements. For balance gait, walk across the room or down the hall, then turn and come back. Observe posture and balance, swinging of the arms and movements of the legs. Normally, balance is easy. The arms swing at the side and turns are accomplished smooth. Next is to walk heel to toe in a straight line, a pattern called tandem walking. Then after that is to walk on the toes, then on the heels, sensitive tests respectively for plantar flexion and dorsiflexion of the ankles, as well as for balance. Next is to hop in place on each foot in turn, open and close eyes 3 times. Next is to do a shallow knee bend. First one leg, then on the other. Then support the patient's elbow if you think the patient is in danger for falling. Next is rising from a sitting position without arm support and stepping up on a sturdy stool. A more suitable test than hopping or knee bends when patients are old or less robust. Next is to test for pronator drip. The patient should stand for 20 to 30 seconds with both arms straight forward, palms up, and with eyes closed. For muscle bulk, compare the size and contour of muscles. Do the muscles look flat or concave, suggesting atrophy? If so, is the process unilateral or bilateral? Is it proximal or distal? When looking for atrophy, pay particular attention to the hands, shoulders, and thighs. For muscle strength, test the muscle strength by asking the patient to move actively against your resistance and to resist your movement. Remember that a muscle is strongest when shortest and weakest when longest. For flexion in the biceps, test flexion at the elbow by having the patient pull and push against your hand. For extension, triceps extension at the elbow by having the patient pull and push against your hands. Then now, extension at the wrist. Test the extension at the wrist by asking the patient to make a fist at resist your pulling down. And weakest of the extension is seen in the peripheral nerve disease and in central nervous system disease producing hemiplegia. Test the grip. Ask the patient to squeeze 2 of your fingers as hard as possible and not let them go. To avoid getting hurt by hard squeezes, place your own middle finger on the top of your index finger. You should normally have difficulty removing the fingers from the patient's grip. Testing both grips simultaneously with arms extended in the lap facilitates comparison. Now test finger abduction. Position the patient hand with palm down and fingers spread, instructing the patient to not let move the fingers and try to force them together. Then test the opposite of the thumb. The patient should try to touch the tip of the little finger with the thumb against your resistance. Then now test flexion at the hip by placing your hand on the patient's thigh and asking the patient to raise the legs against your hand. Then test abduction at the hips. Place your hands firmly on the bed between the patient's knee, then ask the patient to bring both legs together. Then test abduction of the hips. Place your hand firmly on the bed outside of the patient's knee, then ask the patient to spread both legs against your hand. Next is to test the extension at the hips. Have the client push the posterior thigh down against your hand. The next is to test the extension at the knee. Support the knee in the flexion and ask the patient to straighten the leg against your hand. The quadricep is the strongest muscle in the body, so expect a push-pull response. The next is to test the flexion at the knee. Place the patient's leg so that knee is flexed with the foot resting on the bed. Then tell the patient to keep foot down to try this. Then test the flexion at the knee. Place the patient's leg so that the knee is flexed with the foot resting on the bed. Then tell the patient to keep the foot down as you try to straighten them. Next is to test the dorsiflexion at the ankle by asking the patient to pull you. Next is to test the plantar flexion and push down against your hand.
Tulak mo pababa, akong tigilan. Tulak mo pababa. Tulak mo. Sige pa. Sige na.
And now for the last procedure, assessing the reflexes, the tricep reflex sitting down. Flex the client's arm at the elbow with the palm toward the body and pull it slightly across the chest. Strike the triceps tendon above the elbow. Use a direct blow from directly behind it. Watch for contraction of the tricep muscle and extension at the elbow. Now for the supinator reflex, the client hand should rest on the abdomen or the lap with the forearm partly pronated. Strike the radius about 1 to 2 inches above the wrist and watch for flexion and supination of the forearm. Next is the abdominal reflexes test. The abdominal reflexes by briskly stroking each side of the abdomen, above and below the umbilicus, in a direction is illustrated. Note the contraction of the abdominal muscles and deviation of the umbilicus toward the stimulus. In obese patient, in order to mask the abdominal reflex, use your finger to retract the patient's umbilicus away from the side of the to be stimulated. Feel with your retracting finger for the muscular contraction. Abdominal reflexes may be absent in both central and peripheral nervous system disorder. The knee reflex. The patient may be either sitting or laying down as long as the knee is flexed. Briskly tap the patellar tendon just below the patella. Note contraction of the quadricep with extension of the knee. A hand on the patient anterior thigh lets you feel this reflex. The ankle reflex. Primarily, the client is laying down, flex one leg at both hip and knee, and rotatedly externally so that the lower leg rests across the opposite shin. Then dorsiflex the foot at the ankle and strike the Achilles tendon. The plantar response, with an object such as key or the wooden end of the applicator stick, stroke the lateral aspect of the sole from the heel to the ball of the foot, curving medially across the ball. Use the lightest stimulus that will provoke a response, but be increasingly firm if necessary. Note movement of the toes, normally flexion.
After the procedure, lower the bed and assist the patient to a comfortable position. Then, thank you po ma'am sa cooperation. Then after that is to gather all the necessary materials used. Then dispose them properly. Remove gloves. And perform hand hygiene. And then document care. Document the result. Note for the time and also the assessment of the patient result. Then also note for abnormal signs. Then notify the physicians for the abnormal